But because younger patients often have delays in diagnoses, that the aggressiveness of the tumors as well as those delays often lead to younger patients being diagnosed at later stages, which obviously when that happens, it's sometimes harder to intervene and fully cure a cancer in those cases.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Margaret Gatti-Mays. Margaret specializes in breast cancer, immunotherapy, and early-stage clinical trials, and she is the section chief of the breast medical oncology at the Stephanie Spielman Comprehensive Breast Center. She will fill us in and we'll talk about early-stage breast cancer, what it is, advances in detection and treatment, and how and why the James is a national leader in this important field and why this is so very, very important. Welcome back to the podcast.
Thank you so much for having me back, Steve.
Well, I'm very interested in talking about this. Early onset cancer in all the different cancers has become a very important topic, and the James is really leading in this direction. We've done 3 or 4 podcasts on this, and now today we're going to center on early onset breast cancer. So first, kind of explain to us what that means, that term.
So early onset breast cancer typically means onset of breast cancer in younger patients. And so there's a couple of different definitions, but typically we'll categorize that as patients who are 45 and under with a new diagnosis of breast cancer.
Now, typically, if I get my numbers right, the average age is somewhere like 60 or above, isn't it, traditionally?
Correct. Yeah. Average age is about 62 to 64, depending on kind of the year and the data set. And so this onset in early onset breast cancer generally tends to be about 15 to 20 years younger than that average age.
Are you seeing more and more of these? Because I know we're seeing more younger patients with colorectal cancer and some other cancers.
Yes, absolutely. Unfortunately, we're seeing more young patients developing breast cancers. The 2026 Cancer Statistics Report actually was just released last week. And in that, they consistently found another increase in breast cancer diagnoses overall of about 1% per year increase since 2013. But when they looked specifically at younger patients, which were under the age of 50, that increase per year was 1.4%, whereas in those patients that were 50 and older, it was 0.7%. So
they're driving the increase. And 1% a year doesn't sound like much, but over 3-4 years, that really becomes thousands and thousands of women.
Exactly. And just an example to kind of see, while it doesn't seem like a lot, when we think about it each year, and especially because breast cancer historically has been considered a cancer that occurs in later years, so in your 60s, when we're thinking of patients that are under the age of 45 specifically, when those cancer statistics came out in 2024, your risk of cancer in that age group essentially was 1 out of 48. However, with the cancer statistics that just came out this year, it's 1 out of 46. So we can see just in a 2-year period, when we think of kind of the number of patients that are impacted, it really is unfortunately increasing in our younger patients.
And I mean, there could be 46 million women in that age group. So
exactly.
That's a lot of women that need to be educated and know what to do, which
absolutely
you're going to help them. Why do you know why there's an increase in younger patients?
Sure. So there's a couple of different reasons. The one thing people will often point to with younger patients is saying, well, it's a genetic predisposition. We've not really seen any significant increases, though, in the percentage of our patients that have germline mutations that cause breast cancers like BRCA1 or BRCA2, PALB2 or CHEK2. But what we have seen is some of the social determinants perhaps that may impact cancer risk. So what we are seeing is that in many of our young patients that fertility risk is decreased over the last several years. And so when back in
meaning women are putting off having babies, or there's less and having less babies.
Exactly. So, for example, in 1998, about 42% of women of childbearing age had not had a pregnancy during that time, whereas the most recent data, I think, which was from 2022, estimates at about 50% now. And so with decreasing fertility rates, so either putting off pregnancy or not having a pregnancy, that can increase the risk of breast cancer. We can also see increases in breast cancer risk because because of higher rates of obesity that we're seeing, also lower activity levels,
Right.
and also alcohol risk, which is one of the modifiable risks that most people don't think about. Even one drink of alcohol a day can significantly increase a woman's risk of developing breast cancer over her lifetime.
And you can extend that even further, that alcohol increases the risk of many kinds of cancer.
Absolutely.
You mentioned briefly that inherited genetic diseases don't seem to play a big role in the increase in younger women. How about just family history? Is that something that can impact it?
So family history absolutely can. Only about 8 to 9% of all of the patients we see in breast cancer clinics have breast cancers that are associated with BRCA mutations or other germline mutations. So the vast majority of our patients do not have a germline mutation, although obviously if they have one, their risk of developing breast cancer is higher than the average woman. However, we do see significant family histories in a lot of our patients, and so that can be a good indicator of a woman's elevated breast cancer risk as well.
So what should a younger woman, so let's just pick an age, 20 or early 20s, be asking her parents and family members? What would be something that would set off a warning sign in a woman's family?
Sure. So I think it's important first just to know the family history. I think a lot of times in families, especially when it comes to cancer, even now, but especially, 20 years ago, people didn't often talk about family members that had cancer or distant relatives that had cancer. I think it's really important for everybody to know their family history, specifically when it comes to cancers, and not only breast cancer, because we do see breast cancer can be part of genetic syndromes that lead to other cancer types too. So I think patients in general, just knowing that history, being aware of the family history, and making sure that if breast cancer or other associated cancer like ovarian cancer, prostate cancer, pancreatic cancer, or melanoma runs in the family, that those patients start the conversation with their primary cares about potential cancer screenings, not just for breast cancer, but for all of those types of associated cancers as well.
Right. There are so many great screening things that we have now, mammograms,
There are.
colonoscopies,
There are.
pap smears. There's so many really great tests. Are the cancers that younger women get, the breast cancers that younger women get, different than the breast cancer that a woman 65 or older would get?
Absolutely. So what's interesting is when we look at breast cancers that occur in younger women, we do tend to find a higher incidence of more aggressive breast cancer subtypes like triple negative breast cancer, and then a type of hormone receptor positive breast cancer that tends to be a little bit more aggressive called luminal B. This is important because these cancers not only are they more aggressive, but because younger patients often have delays in diagnoses, that the aggressiveness of the tumors as well as those delays often lead to younger patients being diagnosed at later stages, which obviously when that happens, it's sometimes harder to intervene and fully cure a cancer in those cases.
Right. I mean, when you can catch breast cancer in the earliest stage before it's spread, the rate of survival and success is tremendous.
Absolutely.
Well, that leads us into this whole screening process. So typically, or what is the age that women are supposed to start mammograms?
Sure. And so, Steve, this is actually, I find one of the really important kind of points when it comes to thinking about younger patients with breast cancer is because screening recommendations usually start at 40.
Right.
So the average risk woman should start screening mammograms at the age of 40. Now, there's some differences, whether it's an annual mammogram at 40 or every other year at 40, depending on which guidelines we look at. However, most patients, when we think about that early onset breast cancer age group of 45 and younger, or even 40 and younger, those 40 and under patients are not going to be having annual mammograms.
Which is why they're being diagnosed in later stages.
Exactly. I think that's part of it is mammograms we know are very effective in detecting small tumors at early stages. But I think the other part that I find is often a misconception is when we have patients in their 20s and they go to seek medical care, they'll often be told, well, you're too young to have breast cancer. And I think that that's one of the pieces of the narrative that I know myself and colleagues at the Spielman would really like to change. Is in my experience, I think you're never too young to have breast cancer. And so if there's a mass, if there's a change in the breast, if there's swelling, if a woman knows any change at all in the breast, it's really important to seek medical care. And it's really important for medical professionals to recognize the fact that we're seeing cancers in younger and younger patients.
Are you saying that sometimes a woman in her 20s or 30s will go in and say, I'm having some discomfort or I feel something, and the primary care physician will think you're too young and not follow up?
Absolutely. And I think it's not even that they're, it's not necessarily the primary care. A lot of times these patients will end up in the emergency room, will end up in urgent care, because in some cases, specifically some of these aggressive types like inflammatory breast cancer, which we do see in younger patients, the signs and symptoms are a swollen red breast or a palpable breast mass. In many times, because this looks similar to a benign condition like mastitis that women can get after pregnancy, a lot of times these kind of subtle symptoms are easily misdiagnosed as benign syndromes. And I think when it comes to breast masses, just because younger women can have fibrocystic breast masses, they can have cysts that change with menstruation, that a lot of times these masses that may come up are initially misdiagnosed as benign. And I think obviously for what I always advise.
They're misdiagnosed without a mammogram.
Exactly.
They're just by
physical exam and by history. And so what I usually try to implore to patients or to family members or patient advocates when I'm talking with them about early onset breast cancer is that one of the most important things a woman can do, or men, because men also get breast cancer, is that if there's a change in the breast, if there's a change in the armpit, if there's anything that, especially where the symptoms are sustained, it's really important to be an advocate for yourself. And even if you've gone to have it evaluated and we're told that it's benign, if it's persistent and progressive, it's really important to get it checked out. Sometimes those actions can actually make a big difference in patients being diagnosed earlier, because patients will say something wasn't right, and I kind of kept pushing.
That was the key word I was thinking before you said it, is advocate. You've got to be an advocate for yourself and say, I really feel like I need to get a mammogram so I can have peace of mind.
Absolutely.
And or to determine that I do have early stage breast cancer. Because I mean, I'm not sure if you know the statistics right off the top of your head, but when it's caught in that first stage, what is the cure rate? Yeah,
so there was actually some really impressive statistics that were just released actually from breast cancer, that when it's caught in early stages, about 95% of patients are still alive at 5 years and still doing very well. And so, while some people will say, oh, that doesn't seem like it's enough. When we look kind of over the history of breast cancer, that number has been steadily increasing. And so it is when we catch it early, when we're able to intervene early, the likelihood of being cured of a cancer is much higher than if we catch it in the later stages.
Yeah, that's true. 5 or 10 years from now, that number might be 98 or 99%.
Yeah.
And I guess your goal is to get it to 100.
Absolutely.
Wow. Okay, that was a great overview of some of the basics, and we're going to take a quick break and come back and look at some of the research and programs that the James is working on.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Dr. Margaret Gatti-Mays, and during the quick break, you checked the statistic that you just talked about and found that the news is even better than we thought.
Right. So, after I had mentioned the 95% statistic, I was like,
I saw that look on your face.
I was like, wait a minute, I think we actually did better. And so within the last month, actually, newer breast cancer survival statistics were just released. And so when breast cancer is caught in the early stages, the relative survival rate at 5 years is 99%.
Wow, 99. Wow. And I'm taking that's from a combination of things: better screening, better treatment,
Absolutely,
and like immunotherapy and science. It's better
Absolutely.
science. The things that you guys do every day. 99%. That's amazing. So that's just shows you how important it is to catch this early. You have a 99% chance to be alive in 5 years. Wow. And before we get to that a little more, but first, something else we wanted to talk about is younger patients are at different points in their lives than older patients and might have different kind of family and financial stress.
Absolutely. So I think that that's one of the other parts of caring for younger patients with breast cancer that I think is really important as discussion of the care plans evolve. Patients that are younger, 45 and under, that are diagnosed with breast cancer generally tend to be in a different life stage than those patients that are diagnosed in their 60s. So younger patients often have young children, and obviously there's a lot of concerns about being able to not only care for the children, but being able to be around for the kids as they grow up and as they get older and have kids of their own. There's also, obviously, much of that generation is also the sandwich generation. And so there's also caring for elderly parents. And that's a big part of the concern as well. Family members, parents may have moved in with their adult children or are relying on them for care or for financial reasons. There's also individuals who are in their 40s, in their 30s. Often that's when many of them are still working, right? Still earning or putting away savings. And so work is really important in order to maintain insurance, and you need insurance to get health care. And so all of these factors, while they definitely exist for all of my patients, no matter what age range, I feel like we see a slightly different set of priorities and concerns specifically for our younger patients. And to the point that some of these concerns actually can impede patients being able to come in for their treatments. I've had patients where care is, delayed because they couldn't find childcare for their kid. And when, you have a 30-year-old single mom who needs to come in for chemotherapy, she can't work because she's on chemotherapy for her breast cancer. What does she do with her child if she doesn't have a support network around, right? And these, I think, are very unique considerations that we have to have as physicians when we take care of these patients, is because we're not just providing care to that patient for just the breast cancer. We have to think of all of their social situations.
Wow. And you are right that younger people have a unique set of stresses and strains and problems. And we just did a podcast with Sarah Myers and John Alexander, two of your colleagues, who talked about the pretty new James Bridge program that they're in charge of. And that's not your specific area of expertise, but can you just give us a little hint about what that program does and how it helps younger cancer patients sort of find the different services and treatments and communities they need?
Sure. So the Bridge program, I think, is an incredible initiative by Dr. Myers and Dr. Alexander, and I'm so excited to be able to have that here at the James for our patients. I think it's going to make a huge difference for many of the young patients that I take care of at the Spielman in the breast program. The Bridge program essentially is really focusing on not only caring for these younger patients, so making sure that the treatments are obviously appropriate, but helping to provide some of that additional support that's needed. One of the other aspects of being a young patient with cancer is often these patients are not able to participate in clinical trials because of their other responsibilities. And so we generally tend to have an underrepresentation of young patients with these aggressive cancers in clinical trials. One of the pillars of the Bridge program is to enhance research specifically in some of these more aggressive cancers in younger patients. And then advocacy, I think that's another really important part for younger patients. Being a young patient with cancer can be very isolating. And so the Bridge program is really hoping to help unite and really put forth really strong patient advocates to help push forward some of the critical steps to improving outcomes for patients that are young and diagnosed with cancer.
Now, I had to write this down, but BRIDGE is an acronym, and it stands for Building Research, Innovation, and Care Delivery for Groups with Early Onset Cancers. Now, you mentioned an important part of the BRIDGE program is research. And can you talk a little bit about what's going on in the area of breast cancer research for younger patients?
Sure. So I think there's a couple of really interesting areas in breast cancer, specifically focusing on younger patients with breast cancer. So obviously, we want to make sure that we are accruing and enrolling patients that are under 45 to clinical trials, having a clinical trial patient population that's representative of the patients you treat with that agent once it becomes standard of care is really important. And so, as I mentioned, often younger patients are underrepresented in clinical trials because of their other responsibilities. It's difficult to find time or to commit to the trials. But it's really important because these tumors do seem to be biologically different and more aggressive. We're also looking in many of these clinical trials about longer-term effects of side effects. And I think that that's really important, especially...
Because these patients are going to live longer, 30, 40, 50 years, hopefully.
That's the hope, yeah. And so, especially in immunotherapy, where, we see a lot of patients that are young have triple-negative breast cancer, so again, a more aggressive subtype. So we tend to use more immunotherapy in triple-negative breast cancer. I'm really interested, along with several of my colleagues here, specifically Dr. Alexa Mira, and then some of our other colleagues in survivorship, like Dr. Ashley Davenport, about what are the long-term effects of some of these agents. So if we can cure a young patient with her breast cancer using immunotherapy or some of these other novel agents, what are going to be the long-term effects when that patient's in her 50s or her 60s, because hopefully we've cured her cancer. And so it's really important as we improve outcomes to look at the long-term effects, but I think especially in these younger patients, because they have a longer time, hopefully, to live.
Let's sort of talk about a specific maybe patient that you've treated and some of the kind of issues she and her family faced and how you helped her deal with them.
Sure. So I think, I can think of probably hundreds of patients that I've taken care of over the years. And many of them actually have very similar stories in the sense that often, patient in her late 20s will go and find a breast mass, perhaps while she's pregnant. And breast mass is felt, goes, seeks care. So, oh, you're pregnant. This is nothing to worry about. It's just lactation changes. And by the time, additional testing is eventually done, the cancer is very advanced, right? And so that, I think, is one of those, unfortunately, sad but very similar stories that we see in younger patients with breast cancer, whether it's a stage 3 or metastatic. And when we start to really, see those patients in our clinic, obviously talking about starting chemotherapy, there's concerns about, well, who's going to take care of my kids? How am I going to be able to get here, right? Because if it's, there's kids to take care of, there's transportation needs, getting the patients back and forth to chemo. Younger patients will often be very concerned about their hair, right? And not necessarily from a vanity perspective, but for their kids, right? They don't want to scare their kids if they don't have hair, right? They want to be out at the soccer game on the sideline and cheering for their kids, not having everybody ask, well, how are you doing? What's going on, right? They want to have it be normal. And so all of those, I think, are part of that conversation when we start. We often, with younger patients, will engage our social work and financial counselors early because a lot of patients will have significant financial concerns about therapy. Again, many patients will not have saved a significant amount, so they're worried about not only their ability to work, but pay their medical bills. Fertility becomes a major question and an issue. And so whether these patients are pregnant at the time of diagnosis or want to become pregnant after their diagnosis, we engage fertility experts early on. So we have a great oncofertility program here. We work very closely with the physicians in the gynecology OB group in order to help figure out if we can do egg preservation for some of our patients. We also will work with them for fertility counseling, because sometimes where, depending on how old the patient may be, if somebody was in her mid-30s and was thinking she was going to get pregnant in the next, couple of years, well, chemotherapy can actually make it very hard for a woman to get pregnant after she receives chemo. So working with that fertility team to make sure that patients can live their life after cancer. We also, when we tend to think of, the toxicities of the chemo, working with the patients so that they can be able to do their responsibilities. So whether it's going to work, whether it's caring for their children. It's important for all of our patients to listen to them about what they're saying and what symptoms they're having. But I think especially with younger patients, they're sometimes a little bit more forthcoming about the symptoms that truly are problematic because of the fact that they have all of these other things that they need to do. And working with family members, if they want to be involved, we often will encourage the younger patients to consider bringing their kids to infusion, especially patients that have, children that are, kind of in maybe, 5 to 12 range, or even teenagers. Sometimes things are less scary if
maybe
the
to
kids
demystify it for the children, that mom's not just going away and you don't know, it's a mystery thing. This is what it is, and it's
exactly. And they, sometimes when the kids can be part of the care, it is less scary for them, but it also relieves a lot of pressure on the patients, because the patients, they don't want their kids to see them sick. They don't want them to be stressed. But I think when the kids know what's going on, and our nursing teams are fantastic about making sure that there's the opportunity for families to do that.
Well, this has been a great overview. It seems to me the takeaway is women should know their family history, talk to their primary care physician about it, do self-exams, and if you find anything the least bit suspicious, talk to your primary care physician and be an advocate.
Absolutely.
Wow. And if they do all those things, knock on wood, if they were to develop breast cancer, they'll be in that 99% group and do great.
That's the hope. And I think, to that, I would add as well, if a mass is not going away, if it's persistent and progressive, even if a patient's told that this is nothing, right, to listen to your gut.
Yeah.
Right? That's the way you're the advocate. You know your body better than anybody else. And so if something's not right, keep pushing. And I think from that perspective, we have great treatments nowadays. We have incredible ways that we can support our young patients. And so while it's really scary, obviously, for anybody to have a diagnosis of cancer, patients do much better than they used to do. And we have incredible options for patients, which I think is one of the most important takeaways that I can implore for any patients, is that what we're doing now, not only in clinical settings, but also in research, gives us tremendous hope for how we're going to continue to improve the outcomes for our patients.
Wow, that's a great way to finish. We have tremendous hope for our patients.
Absolutely.
And you're a big part of that. And thank you for sharing all this great information.
Thank you for having me, Steve.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.